So if there's anybody that can help us understand our way through Medicines Optimisation, then I'm sure Richard is the man for the job. So maybe we could welcome him now, and then we'll listen to what he's got to say and take some questions afterwards. Richard.
Thank you, Keith. Thanks. Wow, what a turnout. Fantastic. Thank you, first of all, very much indeed for providing me with lunch, which is always very welcome. Thank you also for inviting me to come and talk to you in Nottingham, which is literally just up the road from me in Birmingham, to talk to you during your Medicines Week. It is really quite a privilege to do that and to talk to so many of you on the grand round. So, as Keith said, I am the Chief Pharmacist at the NHS Trust Development Authority. It's a little bit of a misnomer because I'm actually the only pharmacist at the Trust Development Authority, so to be honest I could call myself whatever I like. So I've also added in the title Clinical Lead for Medicines Optimisation. It's one of the things that gets me up in the morning to do the job. I am passionate about medication, particularly medication safety, but actually what's at the heart of Medicines Optimisation, and that's really what does it mean for patients. So just a little bit about me, as well as Chief Pharmacist at the Trust Development Authority during the day, I sort of do an alter ego thing in the evening. I'm a faculty fellow of the Royal Pharmaceutical Society, and I lead our local pharmacy forum in Birmingham and Solihull to actually try to start to embed Medicines Optimisation not only within our local trusts, but actually across the whole health economy. So what I thought I'd talk about today is just a very brief reminder about why medicines are important to all of us. Quick show of hands, how many doctors in here today? Thank you. How many nurses? A handful. How many pharmacists? Quite a lot. Gosh, you've got a big department. We'll have to talk about that. No, I joke. Don't worry, Mo's suddenly gone very pale. And how many others? Patients or AHPs or? Not? Yeah, a few. Great, thank you. That's fantastic. So why are medicines important to all of us in our work? What the heck is Medicines Optimisation? Is it another buzzword? Is it another fashion? Or is it something really that's at the heart of what we're all trying to do as healthcare professionals, which is provide good quality care and good outcomes for patients? Why is it important to us? Why are we getting so sort of excited about it? I thought for those of you who are not pharmacists, I ought to really talk a little bit about where pharmaceutical services fit in. But I don't want to labour the point because as we go through the presentation, you'll see that actually Medicines Optimisation isn't just about pharmacy. And I think certainly in organisations like yours, and I work with 89 trusts across the country, I think the temptation is to think if it says anything to do with medicines, the obvious place for it to be is on the desk of the chief pharmacist. And actually, whilst pharmacy can take a lead on Medicines Optimisation, they cannot deliver everything that's required, both from a healthcare professional's point of view, but more importantly, from a patient's point of view. Then I'm going to make it a little bit real for you guys here in Nottingham, and I'm going to show you a little bit about how you're doing in terms of your organisation compared to the other trusts that I have a responsibility for within the TDA. So, why are medicines important in NHS trusts? Well, apart from actually patients going and seeing a healthcare professional, it's the most common thing we do to people when they interact with health services. Extraordinarily large amounts of medicines are prescribed and consumed every day. And they are really the cornerstone of modern healthcare, aren't they? All of us in our practice pretty much at some point will come into contact with medicines or medicines use. And yet, despite the fact that actually we use so many, we don't often, or we often don't get it as right as we perhaps should. So we know, and this is information, data taken from the World Health Organization, but it's also been backed up by studies and research globally, but also within this country, that between a third and half of all the medicines that the doctors will prescribe, or you as nurses will administer, or you as pharmacists will dispense, a third to a half of those are not going to be taken by the individual patient as they're intended to be taken. Now, we could spend a whole week talking about the reasons for that, but Medicines Optimisation, at least in part, is trying to address that conundrum, if you like, of how do we, if we believe that medicines are a good thing, and I think that's probably why we give them, we tend to do good, then actually we need to make sure that patients have the confidence and are supported to take them as intended. But of course, medicines, all of them, are toxic if you take them in the wrong dose or at the wrong time, and we know that things don't always go as well as they should. And work done by a chap called Per Mohammed up in Liverpool, actually some time ago now, actually had a look at what was happening when people were coming into hospital, how much of what the admissions that they were seeing had an association with a medicine being taken or not. Now, I think this is probably a conservative estimate, but somewhere between 5 and 8% of all of your hospital admissions, these are your emergency admissions, but some of them will be elective as well, are due to preventable, I underscore that word, preventable, we can do something to change it, adverse effects of medicines. Why is it an underestimate? Well, if a junior doctor in the room will know, if you're clerking a patient in or you're taking their history, then the cause for admission very often is not going to be, oh, by the way, their medicine made them fall over and fracture their neck of femur. It was actually, they fractured their neck of femur. So we don't have good understanding of the way in which medicines can impact on people's lives and the reason for admission. The General Medical Council did some work a number of years ago now, the EQUIP study. Hopefully some of you are familiar with it. And this tells a little bit of an alarming story as well. And what it suggested was that certainly amongst junior doctors who traditionally, historically, and still at the moment are responsible for the majority of prescribing, certainly within hospitals, the error rate was around 9%. So if we kind of average that up a little bit, that's 1 in 10 prescriptions that you as junior doctors write, something goes wrong. For those of you who read beyond the executive summary, because the junior doctors are probably feeling a little bit uncomfortable in the room right now, those of you who read beyond the executive summary also will have found that they looked at what prescribing error rates were within the more senior medical teams. And actually, they are also not quite at that level, but there is something also that we need to be thinking about from a medical point of view about looking at how we improve our prescribing. We know that when patients move from one care setting to another, so whether when they're brought into hospital, when they're discharged from hospital back into community care, or actually, quite often what we see in a hospital trust case, where they're moved from one department to another, so perhaps from your AMU to the ward where they're going to receive the majority of their care, or perhaps they've been admitted from A&E and they've come in to be admitted to your hospital. We know that there is around a 30 to 70% error rate or an unintentional, unintended change in medicines when patients move from one care setting to another. So medicines optimisation, again, is about trying to look at those kind of issues so that we try and minimise those errors as far as possible. Something for the nurses in the room, you will know that you spend up to 40% of your time, this is an average, but studies have been shown that up to 40% of nursing time, and think about how busy you are right now, is spent on something to do with medicines, more often than not administering medicines. And that is a huge amount of time that when you're not doing other things, clearly. And so it's a potentially really important thing that we look at in terms of appropriate use of the workforce and so on and so forth. Medicines waste, if you go back to that point I was making earlier on about 30 to 50% are not taken as intended, medicines waste in the NHS is huge. I mean, they've done studies to actually look at this. The last one that I'm familiar with was one that was done in primary care a couple of years ago. And they estimated that about £300 million per annum is effectively flushed into the River Trent. It goes down the toilet, or it's put into a waste bin, or it's taken back to a pharmacy, and it can't be reused. So that, again, if we're thinking about, if you like, the other side of the medicines optimisation coin, which is effective and cost-effective use of medicines, we need to think about whether the things that we as professionals can do to reduce that amount, that waste as well. Getting towards the bottom of the slide, but this is this is a really important issue that I wanted to highlight. The Chief Medical Officer in her report a couple of years ago, I think it is now about 18 months ago, talks about the catastrophe that potentially we're facing as a result of having antibiotics which no longer work. Antimicrobial resistance is a significant global problem. It is certainly a problem in this country, and there is a lot of work and effort going into looking at how we try to reduce the threat of antimicrobial resistance. And the scenario where actually routine operations that we would have done 20 years ago or even 10 years ago in future will become so much more risky because the prophylactic antibiotic cover we've been expecting and using to prescribe to protect people during those operations will no longer be effective. So we all have a duty and a responsibility around antimicrobial resistance, and of course antimicrobials are drugs. They're medicines, and part of the Medicines Optimisation agenda is looking at antimicrobial resistance. And finally, and really I should put these people at the top of the slide, we have to think about the patients and people who consume medicines. One of the things we do know, because they keep telling us, is actually we don't give them enough information about the medicines that we prescribe for them, or we administer to them, or we dispense for them. And the consequences of that are sometimes that they're not used as intended, sometimes they're taken in a way which is inappropriate for that particular individual, and they end up requiring a further intervention. So, where does medicines optimisation come from, or what is, as a pharmacist, we love to get into starting off with definitions, and let's kind of get that out of the way. So for me, medicines optimisation is summarised in this sort of infographic here. We'll come on to another sort of take on it in a minute or two. But when somebody says medicines optimisation, your mindset should be going into, this is the way that we describe how the NHS will deliver quality use of medicines to improve outcomes for patients. And if you want to think about it in the terms that Lord Darcy used, around quality, they are safety, patient experience, and effectiveness and outcomes of the medicines that we use. And if we get it right, we should be around that intersection where we've balanced out and thought about all of those issues. I'd put up there an aid memoir that it isn't just about pharmacy. If we leave it just to the pharmaceutical profession, then actually we're missing the whole point of medicines optimisation. So my own membership organisation, our Royal College, if you will, the Royal Pharmaceutical Society, has defined this in a slightly different way and have come up with 7 principles. Apologies if you can't see that at the back. I know it's probably a little bit blurred. I will let, Idris has already got the presentation, and if you want a copy of that, then get in touch with Idris and very happily send it to you or share it with you. But essentially, they've put this infographic which describes 7 principles. First of all, improve patient outcomes right at the very top, but also patient-centred approach at the very centre. So this is thinking about it and doing things from the perspective of the consumer of the medicines. It talks about 4 principles, 4 main principles: aiming to understand the patient's experience, evidence-based choice of medicines, and ensuring medicines use as safe as possible, and making medicines optimisation part of all of our everyday practice, not just a pharmacy thing. Although the Royal Pharmaceutical Society took the lead, it was endorsed by the Academy of Medical Royal Colleges, Royal College of Nursing, the Royal College of General Practitioners, the Association of British Pharmaceutical Industry, and I think we sometimes forget the really important role that they play in making sure that we have effective medicines, safe medicines, and that we have a pipeline of new innovative technologies coming to the marketplace. So they also endorsed it, and of course NHS England too. I just want to take a moment or two to tell you a little story about medicines optimisation, or what happens when it goes wrong. This is a story of a lady who manages her medicines at home on her own. She's elderly. She's taking medicines for hypertension. She's got a bit of pain from a hip and knee replacement, so she's been taking pregabalin. Unfortunately, Fortunately, she went on holiday and got a little bit dehydrated and was quite poorly when she came back. She went to see her GP. The GP, bless her, immediately recognised that this wasn't something that she could deal with easily in her surgery and called ahead to the hospital to say, this lady's coming in. She printed out a list of this lady's medicines. Bear in mind, she manages them all at home on her own. And she sent it with her to the local hospital. Her local hospital clerked her in. She sat for 8 hours in what they call their clinical decision unit, during which time she'd missed 2 doses of her medicines. Now, nobody had actually asked her about it, and yet she got the list that the GP had provided. Nobody looked at it, and eventually she was seen. And they said, yes, we think you're dehydrated. We do need to get some fluids into you. We need to collect your electrolyte imbalance. And so they admitted her. Now, it just happened to be a Friday evening before a bank holiday weekend. We know what happens at Fridays before bank holidays. The whole world goes mad, doesn't it? In this case, this lady was admitted to hospital into a acute medical ward, and she'd taken all the medicines with her. They were in the trolley, and I got a phone call on the Saturday, and this lady said to me, I'm not quite sure what's going on with my meds, because I've brought all of my own ones in, and she happens to take slow-release verapamil. These are the things that release the drug over a period of 24 hours. And she said, they brought me my medicines this morning, and I didn't have that one. But I did have some little yellow ones. There were 6 of them. And she said, and I'm feeling a bit woozy. I can see lilac all round the room. Suffice to say that you probably have guessed what has happened. The pharmacy wasn't open. The nursing staff had done what they thought was the right thing, which was to give verapamil, but instead of the slow release, they'd given her 6 standard release tablets to the same dose. And of course, you get a massive dump of the antihypertensive. And when we followed this up later on, we discovered that her blood pressure had dropped during that period to 90/60. So I said, after the incident, I said to this lady, if this happens tomorrow and they bring some little yellow tablets, it shouldn't, because we've had a conversation with the doctors and they've got an electronic prescribing system. So everything's hunky-dory on there. We've had a conversation with the nursing staff who are on duty, and it's the same staff on tomorrow, and they know that you have your own tablets and that they're in the medicines trolley. This lady rang me up the next morning to say, do you know what? They brought those 6 little yellow tablets again and tried to make me take them. This is an example of medicines optimisation not happening. That lady happens to be my mother. So it hits home pretty damn hard when a member of your family is very nearly killed, and I'm not being overly dramatic or overly emotional. She was pretty poorly when medics came around to see her. Her blood pressure was through her boots, and had it not been for an intervention, then goodness only knows what might have happened. But the consequence of that was twofold. Firstly, she spent more time in hospital than she needed to. The second thing is she's absolutely terrified now of going back into hospital, and she doesn't trust doctors, and she doesn't trust nurses, and she doesn't trust pharmacists. The other consequence, the third one, is that although it wasn't reported as a serious incident because there was no harm came to the patient, she's now psychologically and mentally scarred. She has had harm, and it's as a result of medicines optimisation not happening. So, here's a typical medicines pathway. And the reason I wanted to show this slide was to point out to you where medicines optimisation needs to happen. Okay, I'll throw it out. Where do you think medicines optimisation needs to happen? Come on, I can't believe you're all that shy in Nottingham. Where does it need to happen? Everywhere, absolutely. So, right the way through from, if we start in the top left-hand corner here, deciding whether a medicine is appropriate in the first case as part of the management of this patient. If you're A doctor or a prescribing nurse or a prescribing pharmacist, they're deciding on the medicine based on evidence, based on good practice, based on a conversation, heaven forbid, with the patient. The prescription of the medicine, making sure that we actually write the right things on the drug chart or type the right things into our electronic prescribing systems and document why we've done it in the patient's notes. A number of times I go around, and I know you've got CQC coming in September, a number of times I actually go round and you look in patients' notes and you look at their prescription chart, nothing. Why have they been started on X? Why have they stopped Y? Don't know. And now I know we're all very, very busy people, but actually this is really fundamental to good quality care, and it's part of Medicines Optimisation. Generating the so this bit here is more the, I guess in this bit is more the domain of the medics. This bit here is more the domain of pharmacy, and so we have some clinical input, one hopes, although I know at weekends it's not perhaps the same as it is during the week. So those safety nets and those checks and balances that your clinical pharmacists are doing, if you're relying on those as part of your system, you need to know when they're there and when they're not there. So there's some issues there for pharmacy. There's also something about interpreting the order, the actual prescription order. Can you read it? Does it make sense? Are there interactions? Have you got clinical decision support systems to help you with those decisions to be made? Supplying the medicine, well, sometimes it goes wrong, although I think error rates in dispensing in pharmacy are actually very, very low. Partly, I think, because we've got so many electronic systems now to help us in our work. The medicines administration bit, this is predominantly the area of nursing, not exclusively, but predominantly the area of nursing. 80 or 90% of patients' medicines in hospitals, as you know, are given by nursing colleagues. And there's all sorts of issues there. As a registrant with the RCN, you have a code of conduct, you have guidelines around medicines management, they call it, but actually it's about medicines optimisation. You have a unique place and a unique role to play in terms of potential interventions. If you know, for example, that a medicine is not supposed to be given to somebody with kidney failure, and actually you've got a patient who's really dry, then that's when you should be asking the question, is it right to be given this medicine? Preparation and administration, this is an issue, a perennial issue, where we really need to improve. The calculations, making sure that you have an understanding of the basic pharmacology of the drug. What's it going to do to the patient? Because unless you really know, then you can't follow up with the monitoring. And the monitoring can be equally, or is equally important, not least because we need to know whether the medicine's working, and we need to make it as part of our routine check. So medicines optimisation, and the point I'm trying to labour here maybe a little bit, but the point I'm trying to make is actually, it doesn't matter whether you're up here as a medic or a prescribing nurse or a prescribing pharmacist. It doesn't matter whether you're here as a pharmacist or whether you're here as a nurse. Medicines optimisation needs to happen everywhere. It ain't just about what pharmacy does. So some reflective questions for you. I don't expect you to have answers for these, but just some things to think about in your day-to-day practice. And I know there's all real sorts of reasons why you perhaps don't do this, but I just want you to reflect for a moment or two from your professional perspective on whether there is more that you could be doing on a day-to-day basis in your practice. Do you talk about a patient's experience of medicines with them? Do you know whether they are happy to take those tablets? Or have you explained to them what that injection's for? Do they know what some of the side effects might be and how to deal with them? Have you talked with your colleagues how to make medicines use more safe? Very often I go into hospital trusts in particular, and you'll find the pharmacy does its bit, and the medicine does its bit, and nursing does its bit. And there are silos, and you actually, if you remember that diagram we had, you've got to communicate between one another if you're going to effectively work as a team to produce good outcomes from medicines for patients. Do you use evidence base? Why have you selected a particular medicine? Why have you chosen that? Is it supported by, for example, NICE guidelines or Royal College guidelines or whatever it might be? Did you review any high-risk medicines that patients might be on? There are two drugs that really, I would say, annoy me. They probably annoy the patients a hell of a lot more, because we consistently manage to not give insulin properly, and we consistently manage to give people methotrexate daily instead of weekly. Consistently. This last week, part of my role at the TDA is to actually look at serious incidents coming in from trusts. Just this last week, we've had 2 insulins, which were wrong, and we've had another methotrexate given daily instead of weekly. Now, we all know these are the things that, but what is it that's stopping us actually getting better? In the one that I was looking at this week, the patient had actually told the nurses, I don't take this daily, I take it every week, and they'd still given it to her. And she, because she didn't feel empowered, because she was in an unusual environment, she took it. Anyway. Did you talk with other health professionals about optimising the patient's medicines? Did you signpost people to helpful resources, perhaps when they're going out from your trust? Do they know, for example, there's a new medicine service that community pharmacists offer? Do they know that there are practice nurses and GPs, surgeries that can actually help them with their repeat prescriptions and stuff? So, and are there opportunities to employ those principles from that infographic, that round one, in your own practice? So, what does good look like in NHS trusts? Now, this is based on our experience within the TDA. It is based on working closely with CQC. We sort of go round before they arrive to prepare people for a visit, and then we kind of go around afterwards to help people cope with the outcome of the visit. I know you've got a visit in September, and I've just arranged to come up and talk to you about, well, not necessarily you as an individual, but talk to the organisation about some of the things to stop shooting yourself in the foot with the CQC inspection. So what does good look like from our point of view? Well, a named executive lead for Medicines Optimisation, by which I mean having a medical director or a director of nursing who's a member of the board, who's actually acting as a sponsor or as a champion for appropriate, safe and high quality use of medicines, Medicines Optimisation at board level. Having a strategy for Medicines Optimisation. I know you've all got policies, but actually, what are you trying to achieve with your medicines? And it's probably going to have some pithy mission statements in it. And it's probably going to say we're going to do good things and we're not going to do bad things, and we'll all work together happily. Actually, that's probably not a bad strategy to have, but a lot of organisations don't have them. And unless you have a strategy which is signed off by the board and which the exec team have signed up to, it makes it very difficult if you need resource or if you need to argue your point to actually make that happen. Linked to that strategy, we would say you probably need some sort of development plan or improvement plan. Certainly, you need to be thinking about workforce. So, for example, has this organisation got a workforce strategy for Medicines Optimisation? How many doctors have you got? How many doctors are you going to have? Can non-medical prescribing play a role in what you're trying to achieve as an organisation? So these are the things. How many clinical pharmacists have you got? Have you got a 24-hour, 7-day-a-week service? All sorts of things to think about. Governance as well. Making sure there is a clear, what I call golden thread of governance, so that if I come to your board and say, how are you assured that your doctors, nurses and pharmacists are providing safe services when it comes to medicines? And quite a lot of organisations I go, it's a pharmacy thing. But actually, that doesn't really wear very well with CQC. And actually, as a patient, you would want to think that the trust at least has routine data which has been presented to maybe not the board, but certainly the Quality and Safety Committee about these are the things that are happening with medicines and here are our approaches to improving them. And part of that is regular audit. And I know we're all hugely busy, but I know all junior doctors, foundation year doctors have to do some sort of audit as part of your training. Well, there's loads you could be doing around medicines. Same for pharmacists, actually. Pre-registration and trainee pharmacists, there's loads of medicines audit they could be doing. Hey, how about doing some multidisciplinary audit? Halve the work, double the output. Sounds like some good ideas, and I'm sure Mo and his team will have plenty of medicines audit examples that you could be cracking on with. We do want to try and move all trusts towards electronic prescribing and medicines administration, because if you put systems in place which have automatic safety nets built in, then actually it improves the overall outcomes from a safety point of view. It provides your junior doctors and your other prescribers with a clinical decision support system. And it also makes administration a lot easier from a nursing point of view. There are downsides, however. So we've had a couple of examples recently where junior doctors have moved from one trust with one electronic prescribing system to a different trust with a different system and a whole different set of safety nets. And as a consequence, things fell down the gap. So yes, we want trusts to move towards this, but don't expect to do it overnight. This is something that you have to plan for and probably takes 2 to 3, maybe even 4 years to implement across a whole organisation. Have some plans for 7-day working that include access to medicine and clinical services. So I know there's been a lot of focus on doctors and nurses, safe staffing levels, and I know that people are working over weekends now where perhaps they didn't before, but actually making sure the clinical support services are also there to underpin all of your good work. And I would include pharmacy as part of that for the reasons that I've already talked about. Medicines are so ubiquitous in their use that we can't afford not to. And then looking at staff training, education and competency assessment, and I include for all grades and all professions. So it's not good enough, I don't think, to say we provide training when we induce people into the organisation and then do nothing for the rest of their career with you. It's just not good enough. So, how are trusts doing? I won't labour this point too much because I'm conscious we are moving on in terms of time. We've developed a framework. It's a self-assessment framework which trusts can use, and Nottingham University Hospital has used it, to say, let's have a look at how well we're doing from our own point of view, a self-assessment. It consists of 6 domains, which I've talked about most of them already. Within each domain, there's 6 criteria, and within each criteria, there are 4 levels. Don't worry about that. I'm going to show you a picture. It'll make it all clearer. So here is the domain for strategy, risk, and governance. You can see there's 6. You won't be able to read the writing, by the way, but take it from me that it does make sense. There are 6 criteria within each domain, and within each criteria, you assess yourself on a level of 1 to 4. Okay, so if you do the maths, and all you have to do, this is an Excel spreadsheet, and Mo's had a go at doing it, I know. You click on the radio button for each of these levels, you make the self-assessment, and then you do the maths, you work out what your total score might be. It produces some nice little pictures. So this is actually a radar chart showing your own self-assessment, in this case for the criterion of domain of strategy, risk and governance, and 1 criterion within that, and then you've got the other 5 as well. Right, this is where it gets a little bit interesting. So what I've got is spreadsheets back from all of the trusts that we're responsible for in the Trust Development Authority. And if you do the maths, as I said before, and you add up 4 levels by 6 criteria by 6 domains, the maximum possible score, if you scored 4 for everything, would be 144. If you were really sparing and perhaps a little bit miserly and gave yourself a 1 for everything, the minimum possible score you would get was 36 on that framework. So this is the report that we've had back from Nottingham. The blue lines are acute trusts, the red lines are mental health trusts, the green lines are community services, and the purple are specialist trusts, by which I mean places like the Royal National Orthopaedic Hospital, which only do bones and mostly bones and stuff. Mostly bones. They also do acute services, I'm told. They tell me. You can also then look at a sort of where do we sit in relation to everybody else. So I've looked at the median, and the median for last year was 111. Nottingham University Hospitals NHS Trust self-assessment score was down here, around about 104, 105. It's not bad. It's below the median. And in fact, if we'd have looked at last year's, it was on the median. But everybody's improved and moved up. So there's a bit of a gauntlet thrown out to you. What could you, and this is something that could go into your medicines optimisation strategy. What could this organisation do to actually improve its score along here? There are some issues with it. It's a self-assessment framework, and I know that some people have underscored themselves because they didn't interpret the framework as they should. There are one or two trusts that have overscored themselves and said, we're far better than that, we're going to give ourselves a higher score. From my point of view, I'm not making judgments about it. I'm not saying you should be at a particular level, other than to say, wherever you start from, then I would hope that you have an aspirational goal to improve. And in fact, that's what's happened for most of our trusts this year. It is development, it's not a performance tool, so I wouldn't come to Keith, for example, or your chief executive and say, you're not doing good enough, Nottingham, you need to get up to this level. That's not what it's about. The intention is for this to be used by you to help your own improvement. And certainly for a big trust like this, they've done this at Oxford University Hospitals, for example. Instead of doing a framework for the whole organisation, they've done a framework at each clinical directorate or each divisional level, and then they've compared them so that you can see for yourself whether you've got any hot spots or cold spots around the organisation. It certainly shouldn't be used in isolation as a way of saying, are we good or are we bad? But as an improvement tool, and are we doing better than we were last time we did it, then actually I would commend it to you. Where do pharmaceutical services fit in? Because I said it's not all about pharmacy. How many of you actually, who are not pharmacists, been down to the pharmacy and see what they do? Okay. So, I thought that might possibly be the case. Well done, madam, going and seeing what they do. They do everything to do with drugs, from purchasing, making sure that they get the right things in, right the way through to providing clinical services as well. If you don't know, go and ask Mo or one of his team. I'm sure they'd be delighted to show you around their department and give you a flavour. And I encourage you to do it. Go and see what it is that they do and how what they do contributes to your work and can make your work easier for you. But here are some examples of the sorts of things that a typical hospital pharmacy would do. That one's a little bit old-fashioned up there, but that's a standard dispensary. Here you can see a pharmacist doing a clinical check on a TTA before it actually goes out to the hospital. This is to make sure that what's on the prescription inpatient chart is actually what we're giving the patient when they go out. This is have you got a robot here yet, Mo?
One sec.
Okay. How many people knew there were robots in pharmacy? A few. That's what a robot in pharmacy looks like, typically. And they pick drugs. It's amazing. If for no other reason, go and see Mo's robot. They're amazing. They are amazing. But they are also, this is part of the medicines optimisation agenda. A, they automate the process and make it more efficient. B, these robots tend to make fewer mistakes than pharmacy staff when they're pulling drugs off shelves and things. When it's pulled out of these, so I don't know whether you can see, there are boxes and boxes of medicines here, and there's an arm usually that goes up and down and pulls things in and out. And that thing's a conveyor belt, and what it normally does is drop it down a spiral to your dispensers here, who will actually take that medicine, label it up, make sure it's appropriate and checked, and so on and so forth. But pharmacy isn't just about the tablets we get in boxes. We also do aseptic preparations, so things like TPN, cytotoxics, some places radiopharmacy. This is a pharmacist working in in fact, I think it's a technician, working an isolator to make sure that the product that's being supplied, medicines optimisation again, is of high quality, it's sterile, highly skilled work. Here's a pharmacist looking a bit bemused. Actually, it could be a junior doctor, but I think it's a pharmacist looking a bit bemused. This is an automated drug supply cabinet. So for those of you that are worried about CQC coming around and rattling your cupboards to see whether they're locked and stuff, and who's got the keys and who hasn't got the keys, one of the solutions can be, have you got any of these? Okay, so one of the solutions can be, you have these Medicabinets, where actually individual operators have their code, type in the code, and again, this is a safety net in terms of supply. And there's a young lady doing similar. I think actually that's an out-of-hours cupboard, which is an electronic out-of-hours cupboard. So, key question. Anybody recognise those questions, by the way? Lady at the back there. Who's it? Whose are these? CQC, gold star, you get extra cake. You can have extra cake. So when CQC come in, they will be expecting on the basis of these 5 questions. There's a really quite a nice acronym to it. Well, they probably don't like us using it this way. But has anybody seen the acronym SCREW? I hadn't spotted it until I put it all together. So it's safe, caring, responsive, effective and well led. It is a good one to have in your head. So what questions might they ask? Do you have a medicines optimisation strategy? Do you have a plan, an improvement plan? Are you using a tool like the TDA framework or something else to improve what you do? How are you assured as an organisation that medicines use is safe, it's effective and achieves the desired outcomes for patients? What are you doing to monitor the reduction in risk and from harm from medicines? You know, are there trust-wide initiatives? Well, we know there are. There's Talk Medicines Week for a start. Great idea. And what are you doing about antimicrobial resistance? So those are some things that trusts might ask about, that CQC might ask about. There are loads more, and we'll go through those when I come back up to see you in July. And hopefully this will get spread out around the organisation so that when CQC come in, you get a good or outstanding in the safe domain, which is where most of the medicine stuff happens. So, just to summarise, medicines are important, both to our trust, but more importantly to our patients. Medicines optimisation, those DARSI domains, if you like, safety, effectiveness and outcomes, and patient experience. And it isn't just about pharmaceutical services. It's multi-professional responsibility, and it has to involve, engage the patient as part and parcel of that service delivery. I think that's it from me, but I put a big question up there because I think we have probably got 5 minutes or so, Keith, for questions. So, having heard me rattle on a bit, what are you going to do about it? What are you going to do about medicines optimisation in your individual practice? Anybody thought about, I could do something differently? Come on, be brave. Shout out. Idris, come on, you're looking as though you've got something in your head.
I'd like to empower patients more.
Okay, empower patients more. What about a nurse? Any nurses? You know, loads of them, put your hands up. You've all gone quiet now. What are you going to do differently? What could you do differently? Oh, sorry, miss you.
You need to tell patients more about their medicines along the way.
Yep.
Not wait till they're going home
Yep.
and then try and ram the information down at
Yeah.
that point. Little bits
Yep.
as we go along. When we're starting something new, we should be
Yep.
telling them about it. Or asking them if they actually want to start it.
Absolutely. So, I mean, and it shouldn't make your drug round any longer. In fact, it might make it shorter. So, you know, if you're dishing stuff out of the trolley, and I know we've got patients' own drugs and stuff as well now, which are being used, but have the conversation with them. Do you take these at home? Do you know what they do? Do you know what they're for? Do you know how to get some more when you go out? Because we'll give you a few, but do you know how to get some more? How do you normally take them at home? Do you take them with or after food? Who's going to be able to help you when you get home? Because we can do it for you while you're in here, but actually, when you go out. What about the docs? What about the medics? Anything you've felt inspired to do, or are you pretty happy with how things are at the moment?
I think we need to do a lot around education. I think you made a very good point that we have lots of policies, but I think frontline staff, so often the trainees and nursing, won't have read policies, and actually they're the people doing what they're doing with medicines. So I think that's what I want to say.
I think that's a really important point you've just made, actually, because a lot of trusts fall over, particularly around serious incidents related to medicines, not because they haven't got a policy, but because the policy hasn't been followed. And it's when you do those root cause analyses, why is it that that member of staff or that group of staff didn't follow the policy? And usually there's some sort of explanation that can be addressed, but I think training and education, and actually making it everybody's business to keep up to date with all the other stuff we have to keep up to date with, reading the policy with all the other policies you have to read. But at least if you're doing something really critical, something high risk, making sure that you've done a double check, ask a colleague. You know, for nurses, when you're administering stuff and you're not quite sure about it, check with another colleague, ask a pharmacist, ask another one of your senior nursing staff, the foundation doctors and the junior doctors in training. Go and ask and actually, here's something controversial, if you see something that you don't think's right or you don't understand, is actually be prepared to challenge it. And I know that is actually, in some places, quite countercultural. You don't challenge a consultant, well, maybe you could or you should. Or at least have the conversation with the patient. There was a point that somebody here wanted to make. Sorry, yes.
Like comparing with patients.
Yes.
Two examples you gave about insulin and methotrexate
Yes.
would have been avoided if the patient was able to self-medicate.
Yes.
What do you feel about self-medication, patients who have the capacity to do so?
I think that's really, really hard, and I think you hit the nail on the head when you said the capacity to do so. I do have a lot of sympathy for nursing staff who are very, very busy already, and suddenly we're saying to them, oh, by the way, you've got to do an assessment to see whether this patient's competent to take the medicines, because very many nurses feel very personally responsible if they haven't, been able to do the assessment, and they also feel uncomfortable about letting patients loose with their own meds in my hospital. But actually that's exactly what you'd be doing when patients go home. So yes, I would like to see more self-medication available, but I think we need to make sure it's done in a planned way. We need to make sure it's appropriate for those individuals. I guess the way I would be thinking about it is, rather than what's going to happen while they're here, what happens when they go home? Because if you've got an elderly person who's in for 5 days and they self-medicate at home, and then suddenly they don't for 5 days, by the time they go back out again, particularly if something's changed, then actually they may be really quite confused about what they're supposed to do. So yes, I see the benefits of self-medication and I would advocate it, but I do realise that actually it is quite a tricky thing to get right and safe within hospitals.